Well, we're going to go ahead and we are going to do our lunch panel today. And I am so proud and grateful for the North Hills Family Clinic to be here today. They're phenomenal. And I just have to say, North Hills has been a champion in the integrated behavioral health space here in Arkansas. And they really are leaders in this work. And so I know when we first started talking about integrated behavioral health, introducing some of these concepts, oftentimes when we talk to people, they might be a little hesitant. They may not think about this path as being as linear as Dr. Sideri had showed on her winding path, but North Hills is up for the challenge. And they were really excited and innovative and open to any ideas that have been brought to them about integrated behavioral health. And if we say, we think this might be a tool or a resource that could improve and help patient populations' health, they're all about it. And so I'm really excited and I am thankful for you all today. And I'm going to go ahead and, another piece I just want to say, it's one thing to hear from us. We do lots of different trainings and presentations that you come to. We bring in phenomenal experts and speakers. But when you actually hear from the individual clinic about how did we integrate this into our family practice, and you hear from the BHC what it's like, and then you hear from the patient their experience, I think it brings a whole new level of this is real and this is happening, and it's happening in primary care practices across Arkansas. And so now we have an opportunity today to hear from one of those primary care practices. So with that, I'm going to turn it over to North Hills, and they're going to briefly introduce themselves.
First of all, I would like to give a big thank you to ABEN. They have been so instrumental in helping our clinic understand behavioral health integration and also figuring out some ways that fit well with us to kind of start this process. And so not only the help that y'all have given us, but just the work you're doing around the state, we're very appreciative of that. So I'm going to start off. My name is Pennie Biggerstaff. I am the administrator for North Hills Family Medical Center. I've been there for 34 years now. It was my first job right out of college, and fortunately, Dr. Cobb and Dr. Chris Cobb were kind enough to keep me around for a bit. So I'm very appreciative. Okay. So today, we'd like to share with you about our clinic's experience on this journey with behavioral integration and where we are so far. I'm a hand talker, sorry, that's probably what my problem is. And kind of share with you a little bit about our clinic and what we're currently doing and some things that we're excited about to try this year. And then Dr. Chris Cobb will kind of speak from the physician perspective. And then we have Erica, who's our behavioral health consultant, and she's going to share a little bit about what it practically looks like in our clinic day to day. And then finally, but most important, we have one of our patients, Taylor, here today to kind of share her experience of what it looks like from the patient's side of what the work that we've been trying to do. So I want to give a shout out to our amazing staff and team at North Hills. We have been so fortunate that everyone really came on board with us. We started transformation work. This is our team back here behind. Yep. So we started some transformation work in fall of 2016. It was challenging for us at first. We did a lot of research, went to conferences. I don't know how many things Dr. Cobb and Dr. Chris and I read, just trying to understand and get our minds around everything. And so we kind of did all of that before we really started pushing it out to the staff so that we could have a little idea of what we wanted to try to do. And they have been so great to embrace everything, and we're really appreciative of the way that they have come on board with us and been a part, and we would not have been able to do any of this without them. So just to tell you just a little bit about us, we have 3 providers, a nurse practitioner, and we have just brought on Erica as a behavioral health consultant. We are super excited about that. It's something we've been working on for several years to be able to provide and to do. And then you can see that we have 9 full-time, 3 to 4 part-time, depending on what's going on, and an active patient panel of around 3,600 patients. And then this is just letting you know a little bit about the value-based programs, some of the contracts that we've been involved in the past or are currently involved in, just to give a quick view of some of the work that we have been doing. So as I said, we started this, trying to build this back in 2016. And as we went through all of this material and we were trying to decide what approach we wanted to take, one thing became very evident to us at the beginning. We did not want to get bogged down in to-do lists. Not that they're not valuable. I am very much a to-do list person. We did not want to get bogged down in data. Again, very valuable, but we didn't want to get so immersed in data and to-do lists and checking boxes that we lost sight of the patient. That was really important to us, even before we started doing such a deep dive into the behavioral health integration part. Just trying to start in with the value-based care part. That was so huge to us. And so we really developed this mission statement that you see. I have it on a whiteboard in my office. I talk about it all the time with the staff, that our purpose is to develop strong physician-patient relationships, which in turn is going to lead us to really strong patient health outcomes that's the best for that individual patient. And we really remind ourselves of that. And our care manager is the master at reminding us patients come first around here. And she's constantly having her eye on everyone. And if she feels like they're going about it or we're getting distracted, she's quick to remind us we filter through this first. And so it's awesome to have a champion like that on our team. We also wanted to set some core standards for our staff, and we knew that our staff was going to be our most valuable asset during this process. And so not only, of course, you want to provide quality patient care, and you have to put it on your list because it is the #1 thing, but we needed to include some things that were going to lead us to make that happen, and then that is really working to excel at communication and patient engagement and to be team players, because we really started moving to a team-based approach at this time also. And so we poured a lot of energy before we even started changing things with the staff. We poured with the patients. We started pouring a lot of energy into our staff, having a lot of communication, meetings, really explaining to them why we wanted them to understand why we were doing things the way we were doing them, what our goals were, what we were trying to accomplish, because I think you retain things better and you're better able to execute things if you really understand and you're involved. We do involve everyone at our clinic, the girls that work at the front desk, nurses, MAs, lab people, billing people. Everyone in our clinic is involved in this transformation work, and everybody has a role. We also spent a lot of time on training and really talking things through, using examples of situations that had come up through the week or a particular day, if that was a challenging day. And then obviously working on team building And that takes a little time, so I'm giving you a quick overview, but this is like work from 2016, right? So this has been an evolving process, not just something we were able to throw together in a few weeks or a few months. One of the things that I think is real important to state about the staff is just monitoring the staff overload and fatigue. And basically, in our clinic, the way we're kind of designed, I felt like it kind of fell into two categories. And that is, our staff really did start engaging with the patients. And when you're implementing behavioral health, and you're engaging with patients at that level, and you're looking at patients differently than you've looked at them before, and you're inquiring and asking questions that you didn't ask before, that can be draining, and you take a lot on. And so we've really tried to watch that and monitor it, even get together in informal ways to talk things through when challenging things have happened with our patients. And then Eric and I are actually working on something new for this year where we're really gonna do some assessments with our staff, have quarterly meetings. We've tried to do fun activities, and then you get distracted because you're busy, but get those fun activities thrown back in quarterly and really put some things together to make sure that we're not losing sight of that, because that's why we're able to do this work. But the other thing, and probably one of the biggest lessons for me in getting the foundation set up, is that the other thing that we have at our clinic is Pennie stress. And that's because I am a very high achiever. I have set very high expectations. I don't ask people to do things I'm unwilling to do, but I'm a little bit of a workaholic, which I don't recommend, but I'm unable to change it at this point in my life. So I'm constantly thinking, analyzing, planning, and I just don't have an off switch on my brain. And so it has been brought to my attention by the staff that can sometimes be annoying and frustrating at the same time. So the biggest lesson that I had to learn was to pause. It's okay that everything doesn't get done today. It's okay that all these ideas that we have and that we want to get implemented might not even be done at the end of Q2. You know, I have big charts on my wall, and I would roll out this paper, and I would have all these goals, and then things weren't getting marked off quick enough, and I got all, And so I think that was a huge lesson for me, that I had to learn to pause, let the staff settle in where they were at. It's okay. We might hang out there at a pause for a little while. And then everybody's kind of re-energized, and then we start hitting it again to move to the next step. So basically, I would say, you know, as I'm kind of getting ready to share some practical examples with you, the pauses are important. Listening to each other, having champions. These are things we hear all the time, but it is so true. I was very blessed during this process of trying to facilitate this, that the physicians were champions, you know, for me in the chain of command, but I also had staff members that were champions for me, and then we were able, I mean, at this point, I feel like basically our whole staff are champions for this because we see the value in it. So I just want to kind of share with you for a couple of moments just some very practical things. Again, all of this didn't happen overnight. I'm just trying to pull out some of the highlights of some of the work that we've done. We did start out risk scoring at the beginning. It's very huge. We continue to do that just to kind of help us to have a baseline. We really worked a lot to improve our screening for depression, anxiety, social barriers. We developed some of our own social barriers screenings and put in our EHR just based on experiences that we were having with our patients. We have used telehealth visits. We started out really trying to develop a very strong care management program, And I think that that was one of the successful things that we had. Now that has evolved significantly as well. We started out kind of segmenting things a little bit. We had a care manager, she's amazing. We had somebody doing the hospital ER calls. We had somebody check in to kind of make sure that some other things that we were working on weren't falling through the cracks. But then the girls were coming back to me and saying, I'm feeling a little disconnected from my patients because we're team-based, so we have a team for each provider. And they work on that panel of patients that's attributed to that provider. And they were feeling a little disconnected, and so we just evolved and started changing things to where the care team does their own hospital and ER calls so that they really know what's going on with their patients and they're not disconnected from that. And then continue to develop our care management. And what you start finding is there are a lot of people in your clinic that have a skill set and some value to bring to care management. So I would almost say at this point, although we have someone designated as a care manager, between her setting an example, training, team meetings, I would say care management is pretty much just kind of integrated among our staff, and everyone is doing it at some level. So that's been really fun and exciting to see. We also do chronic care management. We're gonna tear that off a little bit this year and divide that up into, is behavioral health a better focus? Our behavioral health consultant a better fit for this particular patient? Do we need our nurse practitioner involved in this because it's a little more clinical, new diagnosis, in and out of the hospital, long med list? Or is this just somebody we're needing to monitor to kind of help them through this season to make sure that they're being consistent with the care that they need to get good outcomes? We've participated in social worker intern programs through ABIN, which has been huge for us to really start integrating the behavioral health and really seeing the value. And then, as I said, we're going to be bringing Erica on full time. We're super excited about that. We've been wanting this for a while. And then one of the other things that we did that I think does tie into this is last year, and it seems like a simple thing, but we've gotten a lot of results from it, is last year we started a very detailed, not time consuming, but we made a form. So when the patient leaves their appointment, there are very specific instructions completed on this just little internal form we have for their follow-up appointment. It might be something as simple as they're a risk level 1 green, they're healthy, they call us if they're sick, otherwise we just need to see them once a year for a wellness. But we have increased our follow-up with patients to where currently 88% of our patients have an appointment. If I run a report of our active panel, 88% of our patients have an appointment on the book. And I feel really good about that with all the chronic conditions that we deal with and all the things that we have going on. We've really seen a lot of benefit from that, and a lot of benefit has kind of come out of that in a lot of areas because we've been able to have that consistency. So a couple of things that we are looking at for next steps that we're working on for this year is one, the clinical staff care that I talked about, and just kind of really making sure that we stay focused on our staff and we don't lose sight of that. And then we have done patient group work in the past that's been very successful. And so we're wanting to really, COVID kind of put a pause on that, and we're wanting to really get into that again. We've done it with our diabetics. We have done it for patients for grieving. And then we're currently working on some new ideas for this year, and patients have been very responsive to that, and that's something that we're looking forward to. One thing that I'd like to share just for a few minutes is about this expanding role of the care manager. And this just kind of came about by accident. I'm not saying this is a fit for everybody. Like, none of this may necessarily be a fit for you, but for us, this has been very interesting to watch. We always kind of evaluate at the end of the year what we think worked, didn't work during the year, kind of what are our deals to go into the new year. And we knew we were going to be having some transition this year, and Dr. Chris has been taking on a heavier patient load, and we also had noticed that there were a lot more patients in his panel that were having some behavioral health needs. So we were trying to figure out, how are we going to keep his day manageable, because this is starting to stretch out a little bit, and this is going to be a lot for one person to handle. So we were just meeting with some staff. We're just kind of tossing things around. You know, Scribe came up. I know that works great for a lot of people. I've just never seen value in a way to fit it into our clinic to make that be a good fit for us. But I was starting to get to the mindset, are we going to have to do it? Are we going to have to go down a road I really didn't want to go? And our care manager said, let me try it. I think let me try what this Scribe thing would be like. And I'm like, well, that's interesting. I wouldn't have thought of it. Not sure what I think about it, but let's try it. So the end of the year, we tried it a couple of days a week. And then this year we started doing it full time. And it has been mind-blowing. So basically, she goes into the room. She does do some traditional Scribe things. She has her laptop too. She's taken some notes. But as her and as Dr. Chris and Melissa started developing this, they're like, no, this is going to be interactive. He's like, I don't want you sitting there being a scribe, just putting everything down. If you know something about the patient, she's great at navigating and starting conversations. So they have this tag team way that they do things as we're seeing the patients. Now, if somebody's there for a sinus infection, they may decide that there's no need, everything seems good. But the 90% of the patients, she's going in with him. And we started an internal referral system from this. And so what happens is she knows all the resources we have. She stays in touch with Erica, what Erica's working on, what our girl that does the chronic care management, our nurse practitioner participates in some chronic care management and care management for us also. And so now we've got this internal system. She's taking notes, she's putting notes in there. When we do a warm handoff for a patient to Erica, Erica already knows what's going on, what they're needing me to address, what's happening here. And it's just kind of been this fluid thing that has developed that I'm really excited to kind of see how we continue to fine tune this throughout the year. And I think that we're going to get a lot of benefit with our patients. So just to kind of share with you a couple of measurable things that we have accomplished through this process. When we started in 2016, at the end of the year, our diabetics that had an A1C over 9 was around 34%. Our blood pressure compliance was at 78, and we were probably doing depression screening on about 40% of our patients. We really weren't into population health data management at that time. That's kind of when it started kicking off. But when we ended 2023, our A1Cs, our diabetics that had an A1C over 9 was 3.66. Our blood pressure compliance, 96%. And I really think we're screening 100, but that seemed a little like I shouldn't put that on there. So I put 99 because we probably have missed somebody. But those are very measurable things, and it's exciting work to show that to your staff and for them to be able to see, okay, that's measurable. And so we know it works, right? Not just with mental health issues, but with chronic conditions. And it's been very exciting to see what we've been able to do with our patients and their response to it. But what I want to end with is this. And I get emotional about it. We know it works, but here's how you really know it works when you start going in the right direction with this. Yes, you get these amazing patient results, and so that's exciting. And you see all this growth with your staff, and that's exciting. And those are the two most important things. you start changing. That's how you know you're doing something. You look at the patients differently. You look at your staff differently. You take a different approach than you have taken before. And so, just to give you a couple of quick examples, it was so ironic that I got the call yesterday, but I had a call yesterday from a mom wanting to talk about her son. And I put off the call for about an hour because I knew she wasn't going to like what I had to say. I always go review the charts. I'm not going to give details about what was going on because it was very sensitive, but I didn't know that at the time. I thought it was just like this kind of regular call. I review everything. But I told myself, okay, you have to make this call, quit putting it off. She's not going to like what you have to say, but you're going to let her talk first, and you're going to listen, and you're not going to have preconceived ideas. This is how I try to work through with myself. And so I got on the phone, I gave her my deal, and I could tell she wasn't happy with my answer, but she wasn't pushing back on me like I thought that she might. And so she said, I'm at work, may I go into a room so we can talk privately? And then I knew this conversation was going to go to a different place, right? And my job was to listen and not make any assumptions about what I needed to do. And she just told me this very heart-wrenching story of what they have been dealing with their 25-year-old son for the past year and a half. And at the end of the conversation, so before we get to the end, I'm like, okay, clearly I'm taking a different approach to this. We're going to find a solution. So I put the patient on Dr. Crisp's schedule at 8 o'clock this morning. He's used to this from me. And I talked to him ahead of time so he doesn't have surprises. But he rolls with me pretty good. And at the end of the conversation, she started crying and she said, no one has been listening to me. Thank you so much for listening to me. She said, we've had bad experiences. There are 2 doctors we will not go back to. And she said, I haven't even had anybody outside of healthcare to talk to because I don't want them to think differently about my son. And so that is what behavioral health integration is about. The diabetic numbers are nice, yes. The blood pressures are nice, and reducing strokes and cost in healthcare and having people be healthier longer into life. It's awesome. And we're going to keep doing that, and we're not going to lose sight of it. But to me, what behavioral health integration in primary care is you're looking at one patient at a time. You just think about that patient no matter how busy you are. I didn't want to make that call. I was frustrated. I was busy. I was nervous to come here and give this talk, and so I was all uptight about that. But that was 20 minutes that made my day worth it. That's why I went to work. So, some words of encouragement. I just say to you that if a girl that has an accounting degree, is nerdy and an introvert, can be in front of a group of people saying how awesome behavioral health integration in primary care is, then we can all do it. We can all impact one person. We just take one patient at a time. So here's Dr. Chris, and hopefully 8 o'clock wasn't too rough on him this morning.
Good afternoon. It's going to be a hard act to follow. Well, I'm Dr. Chris Cobb. They asked me to give a perspective from a physician standpoint on how behavioral health integration has gone in our practice and the effect it's had on how we see primary care going forward. She said I'm a family practice doctor in North Little Rock. We have 4 providers in our group, 3 physicians and 1 APN. I attended medical school. It's been a long time, so a lot longer than I like to admit. I was at UAMS, did a family practice residency from 99 to 2002, and then joined my father's practice at that time. I feel like from a behavioral health standpoint, I feel like I have a unique perspective on how behavioral health affects primary care because of some of the things I've done historically with work and that kind of thing. In addition to my primary practice, I'm also on staff at the Arkansas State Hospital, where I do medical consultations. I'm also doing the same thing at Bridgeway Hospital. I'm not directly involved in the management of the mental health, but I am part of the team with the psychiatrists and everything. And I feel that involvement lets me see the impact of what we're seeing in behavioral health and mental health as it affects us in primary care. I think one of the main things I want to communicate today for me was how my original view of behavioral health and primary care and my current view have changed. Early in my career, I would say my view of behavioral health integration in primary care was very limited. I probably didn't see the benefit. Well, not probably. I did not see the benefit, no question. I don't know that it was, even in talking to my fellow residents, I don't think they appreciated either the effects of behavioral health and what it was we were trying to accomplish. We were lucky enough at UAMS, we had a very dedicated PhD psychologist who, despite us not being very receptive, tried to really prepare us and dedicate a lot of time to giving us a strong background in behavioral health. One of the things that stuck with me that he said was up to 50% of the people that come into our office will meet the criteria for a DSM-4 diagnosis. I didn't really believe that, to be honest. I felt like it was, just another number, and probably my life experience at the time limited my ability to see that. A lot of those people that come in that have those diagnoses, they're not even there talking about those. They're there talking about their diabetes, their blood pressure, their ingrown toenail, whatever it is we're seeing them for, right? But they're not necessarily getting into those other things that might be fairly important. I felt like a lot of the efforts that our psychologists worked on with us, trying to prepare us, I would say fell on deaf ears a little bit, but not as much as, I didn't forget everything. I'll say that. One of the things I wanted to compare, or at least to bring up, is the role of value-based care programs that have really transformed how we're integrating things now. We finally got the ability to have some support in primary care for our practices and providers to improve quality care. It fell right in line with the mission statement that Pennie mentioned, in our trying to develop a delivery system that provides patient-centered, physician-driven care. Through the efforts of all the work that Pennie's done and the rest of our staff, who are amazing, we were able to get a grant that incorporated behavioral health with a physical presence in our practice that we had not had previously. So before, if we wanted someone to see someone in behavioral health, it was a challenge, to say the least, to figure out how do you get someone from being in your office that needs help fairly quickly and getting them that help. Bridging that gap was a challenge. It was very frustrating. It's hard. Everybody that's in primary care understands that it's a challenge, and that just added to the challenge. As years went by, I felt like the value of having someone dedicated to behavioral health became very obvious. We've changed our workflows. Pennie expanded on that. We did a great job telling you guys. We have, as she calls them, warm handoffs, which never heard that before, and love it because it's exactly what we're able to do now with Erica in the office. If I get bogged down and get behind, which rarely happens, right? If I do that, and I'm in the room with a patient that I feel like has a need, and I just don't feel right leaving the room, it gets me behind. And so when you get behind, that it makes the day harder. It makes it hard on the staff and everybody. And so what Erica has done is made me feel comfortable when we have someone that we know has a need, that it's still being met. And that's something until you see it real time, you can't really appreciate it. Let's see. I think, for me, I often focus with, like Pennie said, we're so metric driven now and all these measurables. Getting lost in the diabetes numbers and the high blood pressure numbers, in obesity, BMI, are we doing all these things? Getting lost in those is very easy. And what we began to see is having the ability to integrate the role of Erica in the clinic and behavioral health into solving these problems. We began identifying risk factors that we incorporated, identifying high-risk individuals, and we incorporated behavioral health visits for those who were struggling to reach their goals in management of chronic diseases. Your diabetics they're still 9 for the 3rd time you've seen them that year on an A1C, and you don't know what else you can do to affect the change. And so what having a behavioral health specialist there can start to dig into some of those things that might be an impediment or barrier. I began to realize that a lot of these people, it's not an intelligence thing, it's not how smart they are, it's not even really a discipline game. A lot of the discipline thing, a lot of them had the desire to get there, they're just struggling. And so identifying that and keeping us from overlooking what might truly be the impediment, to me, was something I've noticed with what we've done. We felt like if we were going to improve the efficiency in our treatment, then addressing the behavioral health needs first became the lens that we all need to kind of start looking through, as opposed to looking at blood pressure numbers, diabetes numbers, and everything else first. It was a much more solution-based approach and a lot less frustrating. As we made these workflow adjustments and the therapeutic conventions, we noticed our staff's focus and morale improved. People became less frustrated. We saw, you finally saw the diabetic with a 9 getting better, and it wasn't because we gave them more medicine. It was because we kind of figured out what was wrong. In hindsight, I wish we would have figured this out earlier. It would have been a lot less frustration. But I love that we're where we are now. The last thing I wanted to mention was, where do you go from here? Demonstrating the value of this is difficult. You can't really measure it like you do everything else. Blood pressure, it's either there or it's not. An A1C, it's there or it's not. The downstream effects of intervening from a behavioral health standpoint in somebody's life and affecting the outcomes of their medical problems that we traditionally are looking at, it's not really easy to measure, right? I mean, I've had people tell me all the time that they've had things happen and that by what we've done, and you figure out, well, wow, wouldn't it be neat if you could quantify that in some way? Well, it's hard, right? But it's easy to show it's there. You just don't know how to truly assign a number to it. And I think, we've been very fortunate having the funding from you guys to have Erica in the office. We've also been fortunate with Blue Cross partnering in pilot programs and being open to that. Without that, we would never be where we were, or where we are, rather. Going forward, you're trying to figure out, okay, how do you demonstrate to insurance and other payers that this is worth doing? And that's the sell, and that's how you make it go forward. Otherwise, I don't really know that it's a sustainable model without better funding and support, right? I don't know how you do it. I mean, if we didn't have the funding, Erica would not have been able to be there, right? And so I think going forward, we're going to have to really work hard on with thought leaders going forward and saying, okay, look, we've demonstrated the value of this, and now we need you guys to step up to the plate, because you're able to appreciate from a financial standpoint what we've done, and we need you to help sustain it. And so I think that's, from our standpoint, that's where we're trying to get to the next step. So Thanks for your time. That's all I had.
Okay, hi, my name is Erica. I'm the MSW intern at North Hills who will be joining full-time as a BHC. So I'm just gonna tell you a little bit about what does having the BHC in the clinic look like in real time. So as both Dr. Chris and Pennie have mentioned, I'm right down the hall in the same clinic, 2 rooms over, from where they are. And so we really approach it from that team perspective. I am looking through the schedule in the morning, reason for visit, finding people who are there for chronic disease visits, finding people who are there for blood pressure, diabetes, people who are there for mood, for depression, and dropping a note in there so that Dr. Chris, Kristen, Dr. Burns, any of the MAs can see, hey, Erica, the behavioral health consultant, would like to see this person. So they can start to prep the patient to see me before they ever hear my name, right? And so most of the referrals are made via warm handoff. Once the physician goes in to see them, they talk a little bit about what's been going on. They mention, hey, we have someone right down the hall if you'd like to come talk to them. Sometimes that looks like, we do a full hour-long assessment depending on what the need is. A lot of times it's 5, 10, 15 minutes because people have to run back to work. They're not really in the mood to talk about everything that day. They weren't prepared for it. But I can at least pop my head in. We can at least address, are there any immediate needs that we need to attend to? And then they can schedule to come back and see me at a later time. And I really can't stress enough the importance of this. I hear so frequently from the patients that I see that they've thought about seeing a therapist before. They've been told they need to see a therapist before. But what that traditionally looks like is you go to your doctor, you're talking about being depressed or anxious. They give you, hopefully, if they're Dr. Chris, some lifestyle factors, education, things they can do, and some medication, and then say, now go find a therapist. And so then they have to Google, or if they're really savvy, go to their insurance website and find out who the participating providers are. And then they have to contact them and hope that they don't have a 6, 8, 12-week waiting period in order to get in to be seen for services. Versus in this model, he says, come down the hall. And the access that provides for patients where they can come see me, they can get stabilized in 1 to 8 visits before I refer them out. Or in some cases, if their need is not as long-standing, if they're suffering from some grief or they just need a little bit of help getting their chronic condition under control, eliminates the need for referral entirely. So that is really, I think, the biggest takeaway for me learning about this model. I did not know much about integrated behavioral health before starting this internship, and my everlasting thanks to the team at ABIN for kind of teaching all of us how this model can work, and to Blue and You, Blue Cross Foundation, for funding it, because it's gotten me a job. So we are using, in that assessment, we are using a lot of the screening tools that have previously been mentioned. I think North Hills does a fantastic job, as we've discussed previously, with the PHQ-2, PHQ-9, implementing GAD-7 for anxiety screening, and using Columbia Suicide Severity Risk Screener as well for those patients for whom it's appropriate. Although after Dr. Horowitz's talk, we might be doing that more often. So, any of those things that we can use as measurables for the success of our patients, how they're doing, and that contact with me oftentimes allows me to dig deeper into the problems. Kind of as Dr. Chris said, they need more time than they can get in a 10, 15-minute clinic appointment. For example, I had a patient who he wasn't using a CPAP, and so he was not sleeping well. He had other health issues as a result, and his answer was always, well, no, I haven't been using it. Well, it turns out he had an apartment fire, and the insurance would only replace it at a cost of $200 a month for him, which was more than he could afford. And so that was the reason he was not compliant on his CPAP, not because he just didn't want to wear it. But it took a lot of digging for me to get to that point with him, and I was able to connect him with companies that sell refurbished CPAPs at a much, much lower cost. So he is now compliant on wearing his CPAP. And those are the kinds of the conversations, the kinds of connections that you can have with people when you have the time, when you have someone dedicated to knowing how to ask those questions, how to get that information from people, and most crucially, greeting them with a non-judgmental stance that you are here to help them, and just asking, how do you need me to help you? And I'll pass it over to Taylor.
Well, hey, my name is Taylor. I am the warm body pass off, but I love that. I love that thought process though, because it was really important for me. I guess my experience was back in 2022, but I had shown up for a wellness visit, and I guess it would have been 4 or 5 months previously. My roommate was actually diagnosed with cancer in September, and she passed very quickly in November. So it was very quick, and I was struggling how to deal with it. I'm very much a compartmentalizer, and so I had shut that part of my life and I had shoved it away, and we were living our best lives. And unfortunately, in all of that, it came out anyway. Isn't that the way it works, right? You compartmentalize, but that emotion comes out anyway. And it manifested for me in panic attacks, and pretty severe panic attacks at that. Where I couldn't do much. And I'd never had panic attacks up to this point before that trauma. And so I didn't really know what to do, how to do. I had no idea. Didn't know how to deal with it. I would just call my family. My family would come over and they just would, box me in and just take care of me from there until I came out of it. But I went to my wellness appointment. And I'm a control freak anyway. I do my own thing. I don't need help. And so I probably come to the doctor once a year, if that sometimes. Sorry, Dr. Cobb. But I'm a control freak. And so it was one of those things where I walked in and I was just a normal wellness visit and they just said, how's it going? And I said, well, not great. And for me to even say that, and I felt comfortable enough to say that anyway. And so to say, hey, I'm not doing great. And they were able to ask, well, what's going on? And it all came out. And they said, well, hold on. We've got this individual. Would you be okay with talking with him? Mike was his name, correct? That was 2 years ago. Sorry, everybody. Teacher brain now. But Mike came in and just kind of asked some preliminary questions. And I said, hey, this is kind of what's been going on. Of course, I got a little emotional, kind of explaining like, hey, like, this is what I'm dealing with. I'm dealing with these debilitating panic attacks. They don't happen super often, but when they happen, I'm done for. And he told me, okay, well, here are some practical ways to pull yourself out of this panic attack. And that was all I needed, honestly. And that was 5 minutes, 7 minutes we talked. And so I immediately after leaving that, I called my family and I was like, I have these tools. And being again, a control freak of my own, but then also I'm very practical. And so to have something to pull my own self out of it instead of having to call family, that was a big deal to me. And so the next time actually that I had a panic attack, which was probably a month later, I was able to, he told me to clench, to kind of clench, to hold on to some things, to find something cold, all of these different strategies. And I was actually able to, I was on the floor, uncontrollably crying, couldn't get it together, and remembered, hey, I can lay. I was on the cold tile floor, so my whole body was on the cold tile floor, and I was doing these things that actually I was able to pull myself out of that panic attack without having my family have to come over and hold me and and make sure that I was okay. So for me, it was a big deal because I thought about, I probably need to go see somebody, because of the trauma that I'd experienced with her passing very quickly. But I was actually able to do those things and pull myself out of these pretty significant panic attacks. And I've only, since that one, I had one on the anniversary of her death, and we used all of those tactics to pull me out of it as well. And so, since then, so that was back in November, I have not had one since. And so all of the things that were given to me in these 5 to 10 minutes have really changed how I deal with what's going on up here in this compartmentalized brain, because I understand the brain. Mine goes a million miles a minute. I get it. So it was crucial, and it was definitely a life-changing thing where I have now tools to be able to pull myself out of some of the tougher things when, those panic attacks when you're dealing with stuff. So thanks, guys.
Dr. Cobb, what would you have done in the past before you had Erica, or before you had your BHC in the clinic? And if she'd been able to say yes, well, I mean, you'd already changed because your staff, when you checked her in, what's going on, y'all listened. And then, so it might have come out that, yeah, she was you might have gone ahead and diagnosed, oh, this is panic attack. That seems like it needs someone else. So what would you have done in the past?
Well, the first thing I would do is probably get behind. And that would be the thing that everybody outside of the room would know about. At that time, Melissa wasn't helping me, and so I would generally stay in the room and counsel the patient myself to the extent that I can. And then we would try to arrange follow-up, again, outpatient. And it's, everybody here I'm sure knows, as Pennie said, it's not good, right? I mean, to find somewhere, and also you're relying on the patient often to be the one that makes the referral. As we can make an appointment or a recommendation, but if I make the appointment, it doesn't mean they're going to go. And so efficiency-wise, it was bad.
Yeah.
I mean, we could help with medicine if we felt like that was a role. As everybody knows, that's incomplete, right? It needs something more, and that something more was a challenge, and I would never have given it a good grade. I mean, I would say we got by.
Yeah. Well, and that's I guess, I just kind of want to keep talking and say what a great model this has been about what team-based care is. You heard that it started with these crazy value-based care programs and measuring A1Cs, and so some clinics will say, okay, we're doing value-based care, and they'll get focused on these little pieces of it, but they don't really integrate it in the whole clinic. And that's one of the things that I'm hearing is Pennie talks about how they've changed the way they talk, to each other and how they approach any patient. And then you're hearing a physician who's really embraced it, and then they've figured out workflows. And so often it really is just a 5 or 10 minutes, somebody to have the insight to say, hey, this can help you. Instead of waiting, really, if we wanted to get an appointment today, it would probably be a week earliest if she would go, because she is a teacher and she works. So just getting someone some outside help. So they did several things. If you're interested in integrated care, they did several things: scrubbing the schedule, planning in advance. So they did a lot of things that work and really are poster children for integrated behavioral health. But it happens, and there's clinics that are doing it. So we just wanted you to see that it happens. Lives get changed. Her life changed. It changed everyone, and then affected their family and people around, and her students. And you're back to teaching. And so I just wanted to say thank you. I know we're out of time, and we wanted to give people time to ask questions and all, but I'm sure they'll be around for a few minutes, if not. I just really wanted to say thanks, and it's been great to work with you all for the last few years as part of these different projects. And we also want to thank Arkansas Blue Cross Blue Shield Blue and You Foundation for they made donations to pay for the social work internship program at 3 of those schools. And so the ABN team and Kim and Caitlin have been doing the training for the interns. And then it leads to, hey, this works and this is a good fit. So just wanted to say thanks to everybody making this happen, and it's been great to meet you.
Thank you.